Thank you very much for this kind invitation. We are covering today the indications and the surgical technique of RPLND done by robotic approach for treatment of testicular cancer. So we're going to cover the role of RPLND in stage 1 disease, and also we're going to describe this technique for post-chemotherapy residual mass. So as you probably know, stage 1 testicular cancer can be divided in stage 1A and stage 1B. Stage 1A comprise patients with no evidence of microscopic, vascular, or lymphatic invasion. And we know that these patients can be treated with active surveillance. It's clear that the recurrence rates are low, and these patients can be rescued with chemotherapy if they have long-term recurrence. So there's no doubt that the primary treatment for stage 1 disease today is active surveillance, and this can be seen both guidelines, the NCCN guidelines. Stage 1A surveillance is the first option, and also in the European guidelines, stage 1A patients with no vascular invasion, surveillance is recommended as the first approach. However, when you talk about high-risk stage 1 NSGCT, which means patients with lymphovascular invasion, then there's it's controversial the best approach for treating those patients. Well, and I would argue that the best treatment for these patients is RPLND, done by the robotic approach. And why is that? Well, first, the site of relapse in more than 80% of these patients is the retroperitoneum. So if you do surgery, you're going to be able to rescue most of the recurrences avoid most of the recurrences in those patients while avoiding chemotherapy. Well, those 16 to 30% of these patients have mature teratoma that need surgery anyway. So if you go for chemo, they're going to need chemo and then surgery for residual mass. Well, the morbidity of a robotic RPLND is very low. If you have a nerve-sparing template, you get less than 2% of retrograde ejaculation. And this is the best approach that gives the patient the lowest burden of treatment, which means the lower number of cycles of chemotherapy and the lowest number of interventions over the time. So that's why we offer in our institution RPLND as the first option for stage 1B disease. Also, as I said, the robotic approach does decrease morbidity. These patients stay in the hospital just one night after surgery. And finally, when you compare surgery to the other approach like surveillance or chemotherapy, we're going to have a much simpler follow-up if you do surgery in terms of imaging tests. If you do chemotherapy, they're going to get a lot of CT scans along the life, evaluating if they have recurrence. And if you do a RPLND, the follow-up is definitely much simpler. So in this table, we compare the burden of treatment with each one of these approaches. If those patients choose surveillance, and you consider that recurrence rates can be as high as 53% if they have a high-risk disease, the total number of cycles of chemotherapy that 100 patients would take would be 166. If those patients choose primary chemotherapy in the high-risk setting, stage 1B disease, the total number of cycles of chemotherapy would be 206. Consider again 100 patients with a high-risk disease. While if you start this patient's treatment with RPLND, the total number of cycles of chemotherapy is only 31%. So RPLND does offer the lowest burden of treatment, the lowest number of cycles of chemotherapy for patients with high-risk disease. And there are and the advantages of offering less chemotherapy is because we know the long-term complications of chemotherapy. For example, the risk of secondary solid tumors. In this analysis of the SEER Medicare database, the risk of a secondary tumor for after chemotherapy for testicular cancer can be as high as 43%. 43% more solid cancers in patients undergoing chemotherapy for testicular cancer. And similarly, same authors evaluating the cardiovascular disease mortality after chemotherapy for testicular cancer, they found that the risk of dying of cardiovascular disease is 36% higher if those young patients get chemotherapy for treating testicular cancer. So when we offer RPLND, we avoid these long-term toxicities related to chemotherapy. That's why if you look at the NCCN guidelines, the primary option for stage 1B disease is nerve-sparing RPLND. The second point that I have to discuss here is what is the best template for a primary RPLND for patients with high-risk disease, stage 1? Well, some institutions recommend full bilateral templates. Some other institutions can recommend a modified template in order to decrease morbidity related to the RPLND. Well, there's no randomized trial comparing these two approaches, a modified template versus full bilateral templates, but we know, looking at the retrospective studies, that outcomes long-term seems to be very similar. So there are multiple templates available in the literature. We don't really know which one is the best. In our institution, we usually use the Indiana template, which is for right testicular disease, we do not dissect the para-aortic lymph nodes. And when you have a left testicular cancer, we do not dissect paracaval and precaval nodes. Why do we choose these templates? If you look at this retrospective analysis with patients with stage 1 disease, the percentage of patients with disease outside the Indiana template is about 3%. So it's a very low risk of having disease outside the boundaries of the template, while we can avoid long-term morbidity like retrograde ejaculation. So that's why we offer this template in our institution. The NCCN guidelines do recommend that templates can be used for RPLND in the primary setting, and I think is the best option for these patients. Talking about the surgical technique, there are two approaches that can be used. We used to use the patient in flank position, like in this picture. Port placement is very similar to a partial nephrectomy with the camera ports, left arm and right arm in the midline, and the fourth arm 4 centimeters away of the iliac crest. This is how we do it. We release the right column in this patient. So, and here we are dissecting the duodenum, and you can see the aorta. So this approach is perfect for a modified template. For example, in this case, if I don't wanna dissect the para-aortic and the pre-aortic nodes, it's a perfect approach for, again, a primary setting. And if you want to do just a unilateral template, you can see the ureter here. So this is the lateral limit of my dissection. And this is the gonadal vessel that we have to dissect all the way to the internal ring. So after finishing these paracaval nodes, and here it's very important to preserve the postganglionic fibers, and I'm going to show you those fibers at the end of the video. So this is the upper limit of my template, the right renal artery and the right renal vein, so we are finished. So this is the sympathetic ganglionic fibers that we have to preserve. We move to the dissection of the interaortocaval nodes. And here we use the fourth arm to lift the vena cava. And here you can see these postganglionic fibers that you have to preserve. Especially in the primary setting, we want to preserve ejaculation in those patients. So here we are clipping and cutting lumbar vein. And again, we use the split and roll technique in order to preserve these postganglionic fibers. This is the right renal artery again. Let me show the preservation of those fibers, and this is the most important point. Again, here you can see another postganglionic fiber, and this is key, and I think when you use magnification of the robotic approach, you can do a better job in terms of preservation of ejaculation, in my opinion. Let me show you the final aspect. So here we finish the aorta. We are lifting the vena cava, the postganglionic fibers all preserved. And I was able to remove the pre-aortic nodes I don't need to do a full bilateral template as this is a primary setting. But we are now doing a different approach. We move to the supine position. In this approach, we put the ports uh, uh, inferior to the umbilical scar. So the camera port is a 12 millimeter port in the midline. When you put all the robotic arms in the inferior quadrant, the left and right inferior quadrant. So we have an approach that is similar to what we do in the open lymphadenectomy. We dock the robo over the left shoulder of the patient. So let me show you how we do that. So we start dissecting the posterior peritoneum. So here you can see the vena cava, and we use the sutures in order to suspend the peritoneum, fixing the peritoneum to the anterior abdominal wall, and you're gonna have a great exposure of the retroperitoneum. So here we have the exposure of the retroperitoneum. We start dissecting the paracaval and the anterior caval nodes. This is the right iliac artery. Again, here you have to be very careful over the inferior mesenteric artery and in the interaortocaval space in order to preserve the postganglionic fibers. And here you see one. This is a postganglionic fiber coming from the postcaval space, and this is very important to preserve in order to preserve ejaculation. This is the precaval nodes. We go all the way up to the right renal vein, and this is the interaortocaval space again. We're going to be able to see this is the right renal vein, and these are the postganglionic fibers. See, we have to see these postganglionic fibers in the retrocaval space, and you have to be gentle in this dissection, use a split and roll technique in order to identify these fibers and preserve it. I think this approach is perfect if you want to do a full bilateral template. You can access the left renal hilum, the para-aortic and pre-aortic nodes without need to repositioning the patient. And this is the greatest advantage, in my opinion, of the supine approach to RPLND. Again, postganglionic fiber here, and let me show you the final aspect. Postganglionic fibers preserved, and this approach is also great for stage 1 disease when you want to preserve those fibers. Let me show you the final aspect, finishing the dissection. This is vena cava, bifurcation of the aorta, inferior mesenteric artery. So this is my conclusion in terms of primary RPLND. For low-risk disease, there's no doubt that active surveillance is the best approach. For high-risk disease, there are 3 options. In my opinion, nerve-sparing RPLND is the best option. The templates, primary RPLND, we can use a template, and we're going to discuss the RPLND for residual mass. And for the robotic approach in the primary setting, in my opinion, is feasible and safe, as I just presented. Quick comments on the use of RPLND for post-chemotherapy residual mass. The clear indication is all residual mass larger than 1 centimeter. Why? The risk of teratoma or viable tumor is about 60%, and there's no way to predict if these patients have only fibrosis. So whenever you have a residual mass larger than 1 centimeter, any SGCT, this patient should undergo RPLND, and this is highlighted in the NCCN guidelines. What is the best template? In this setting, I think you should do a full bilateral template. The risk of extra template disease, if you do a modified template in the post-chemotherapy setting, can be as high as 32%. So I don't believe that we should run the risk of leaving residual tumor, residual teratoma by doing a modified template. We usually do a full bilateral template for residual mass, and this is really the recommendation of the NCCN guidelines. In the post-chemotherapy setting, we should do a full bilateral template. You can do using the same supine position approach, which in my opinion is the best because you have access to both renal hilums. One example, a 6 centimeter residual mass after chemotherapy, pre-caval mass. We use the same approach. We are fixing the retroperitoneum edge into the abdominal wall, and you're gonna have the same exposure of the retroperitoneum. you're going to see that I have a great exposure of the anterior wall of the vena cava. You see that 6 centimeter residual mass, and I can gently dissect. You see, I'm peeling the mass from the interior wall of the vena cava. We have great exposure using this kind of supine position approach. It's safe. If you have any vascular injury, again, we can control it using this technique. And I think the robotic approach is safer than the pure laparoscopic approach, especially in those residual masses where you can suture and you can control bleeding in a safely way compared to the pure laparoscopic approach. You see, we're gently dissecting that residual mass from the vena cava. I have vascular control. I have a great exposure of the vena cava if I need to suture it. And I think this is really the best option, even in the post-chemotherapy setting. Finishing this dissection, I'm going to show you the final aspect, clipping the final part of the mass. And this is what you get. Vena cava totally dissected, the aorta, the bifurcation of the aorta, so inter-aortic cava space dissected. The only situation that I think that we should do RPLND is still using a flank position are those hilar masses, like this patient that have a residual teratoma around the left renal hilum. I think in this setting, we should do in the flank position and have better exposure of the renal hilum. And this is what I usually do for those high residual masses. I like to do in the flank approach. So this is the left renal artery. And you see this patient has residual teratoma around circumferential around the renal hilum. It's hard to do this kind of dissection with the patient in supine position. That's why I usually adopt in this setting the regular flank position like you do in a partial nephrectomy. And you can see I have a great exposure of the aorta. Here we are doing the inter-aortic cava space that can be done in a flank position. Sometimes when you want to do a full bilateral template, like in the residual mass, you have to flip the patient and and change the position in order to do the paracaval and precaval nodes. But really, it's really better. It's a really better approach for the section of the renal hilum. If you want to handle these patients, if you want to do this kind of advanced robotic surgery, you should be able to control complications like this. So this is a patient undergoing a residual mass resection. This is the vena cava, just got an injury to the vena cava. You see I have my assistant compressing the vena cava, trying to avoid the bleeding. I'm trying to get better exposure of the vena cava in order to suture it. And that's the point that you need a good assistant. You need to be calm. And I'm gonna expose the injury to the vena cava. You see I'm gonna get my needle driver in order to suture it. I'm gonna compress the vena cava to the posteriorly in order to decrease the venous return so I can have better exposure of the injury. See, I have my fourth arm here compressing the vena cava. I can see now the injury to the vena cava and I can suture it. So that's one of the greatest advantages of the robotic approach. I can suture, I can fix all kind of vascular injuries using the robotic assistance. And another complication, this is the aorta, this is vena cava, is a flank approach. I accidentally removed the clip from an artery from the aorta. You can see it's a lot of bleeding. My assistant cannot control it. So I use my left arm to compress the aorta again posteriorly. So once I compress the aorta posteriorly, my assistant is now able to suck all the blood, and I'm gonna see one of the lumbar vessels bleeding. See, I compress the lumbar vessel and now I control the situation. I have my assistant sucking all the blood, and I will clip this lumbar vessel that was, I accidentally removed the hemolock from this vessel, and then we control. So in these situations, it's important to have a good assistant that is able to control the bleeding. Finishing, I just want to highlight our systematic review of the literature just published, showing that oncological outcomes of RPLND are acceptable, and also the functional outcomes. If you look at the integrated ejaculation rates in all the series with more than 10 patients published in the literature, the average ejaculation rate preservation of the ejaculation is 92%. And if you look at the recurrence-free survival in all these series, it's around 95% with a median follow-up of 21 months. So short-term oncological outcomes are not compromised by adopting a minimally invasive approach. So these are my conclusions in terms of residual mass. All lesions larger than 1 centimeter should be resected. Template should be full bilateral for this residual mass. And as I presented in this meta-analysis that we just published, the robotic approach is feasible, it's safe, and short-term oncological outcomes are similar to open RPLND. Thank you very much for this invitation. It was an honor to participate in this Mexican meeting. Thank you very much.